Well, good afternoon. I'm the last speaker after the lunchtime, so make sure that I'm going to wake you up. Well, a 70 years old gentleman walks into the clinic of any of us with a history of chronic low back pain long time before. But his main concern for the time he saw you was because of significant reduction of walking distance. He said that he was walking before like 800 meters, no pain, but gradually this is go down shorter and shorter from 800 to 600 to 200, until he said, I'm hardly walking to the end of the corridor of the clinic. Why? Because of aching, cramping pain in the back as well as in the upper thighs. More or less, this is the classical story of a patient with lumbar canal stenosis. Yes, 75% of the population all over the whole world, they experience low back pain once or twice in their life. But out of these 75%, only 0.5% will develop lumbar canal stenosis. This entirety is very important. I think we have to focus on. Well, literally, the definition of lumbar canal stenosis is, or spinal canal stenosis, in fact, is that it goes down into a critical value that causes local neurological compression and may compromise the blood supply to the neural tissue. And if we realize what's going on here, it's not only a matter of the spinal cord inside the spinal canal, but also the blood supply at the level of the cord itself, as well as the reticular blood supply. With the first look, we can differentiate easily between a healthy spinal cord in a healthy spinal canal and another one with stenosis. It's not only at the level of the central canal, but also it does affect the nerve roots on either side, which resulted in the claudicating sciatica, which is the mainstay in the clinical presentation of this patient. Again, with the MRI image, with the first look, you can differentiate between a healthy MRI of the lumbar spine, as well as in comparison with the another one with significant compression here and hallucination here and there. Stenosis always happens more at the mobile segment. Why? Because this is the segment which is more subjected to the degenerative change. And of course, we know that the cervical region is the highly mobile segment in the spinal column and followed by the lumbar spine. That's why it's very uncommon to see a patient with spinal canal stenosis at the level of the dorsal spine. Stenosis may be congenital, but we are always facing or dealing with the acquired one. Yes, it might be acquired on top of congenital, but again, it is acquired. And we have to realize something here, that normally the diameters of the spinal canal, when we deal with it, we deal with the transverse diameter and the sagittal diameter. In the normal person, there is no correlation between both. But in the pathological one, there will be. In terms of what? For instance, if we took the C5 vertebrae, here is the widest part of the spinal canal in the transverse diameter. At T8 vertebrae, this is the narrowest transverse diameter. But when we look at the sagittal image in the MRI even, we don't see this correlation between the narrowing of the transverse and the sagittal. But when we have a pathological stenosis, both of them will be affected, the transverse as well as the sagittal diameter. It's a degenerative change, of course. You have facet hypertrophy of the ligamentum flavum, protruding discs, spondylolisthesis. All these are contributing to the pathogenesis of the stenosis. And as Professor Badawi said in the morning about the domino effect in osteoporosis with collapsing vertebrae, again, we have another domino effect here. It's one problem gets us the other problem. Like problems begets problem. So when you have a disc degeneration with loss of the vertebral height, what would happen? There will be abnormal motion at the facet joints. And also, there will be a bulging of the disc into the anterior part of the spinal canal. This one will definitely lead to formation of osteophytes. And this one will lead to bulging of the redundant ligamentum flavum into the posterior part of the canal. and both together will collectively lead to reduced diameter of the proper spinal canal, as well as the intervertebral foramen exits. So it's domino effect, yes, because it's like that. You have the pathology first in the disc, and then it goes to the facet joint, and then it goes to the ligament, and so on and so on. It's like a vicious circle. And very uncommon to see one pathology only. When you are talking about degenerative change that causes spinal canal stenosis, whether lumbar or cervical, usually you have more than one pathology. Very severe form of canal stenosis, you can predict what I was just talking about. Here there is a modic change with degenerative change at the disc level, and of course spondylolisthesis, we just mentioned about that. Degeneration of the disc, and also the ligament and the facet joint from behind, all mounting to a significant canal stenosis. Actually, there are maybe 2 or 3 main types of the lumbar canal stenosis. One of them, which is very important, is what we call it lateral recess syndrome, where there is a gathering along the side of the pedicle, which the nerve root resides there. So it's proximal to the neural foramen. So the spinal canal stenosis itself, part of it is the stenosis of the lateral recess. Again, we might have a lateral recess syndrome at all, or lateral recess stenosis, but it's very uncommon, because usually it's a part of the other main pathology. Well, what kind of conservative treatment? Of course, there is an indication for this until, if there is no progressive neurological muscle weakness, or there is no sphincteric dysfunction, and the history is recent. So you can go for the conservative steps like rest, support. Those people with lumbar canal stenosis tend to have a flat back, because they avoid the hyperextension, which caused more reduction of the diameter of the canal, so they always tend to go for the flexion. So support might help. Exercise like stretch exercise or hanging over a bar, it might help to some extent in the lumbar spine, not in the cervical, of course. Treatment of muscle weakness, because we always consider the muscle is the third column to support the spinal column after the ligaments. Physiotherapy, we might have a kind of exercise, as I did talk about, Williams or Mackenzie. You can have like 30 minutes of ultrasound or infrared per day for a month, and then you see. And of course, you're always monitoring and following the patient to see how the effect. Epidural, it has a rule also, but it is limited. And lastly, the salmon catch thing. I can be at a rheumatology conference, and I will not talk about it, otherwise somebody will kill me, so I have to respect myself. Well, this is an example of the exercise, what we are doing here. This is like stretch, single knee, double knee stretch, this, and also here we have the lower abdomen crunching or walking, and this is the hanging. All of this, it might help. I'm not saying that it is definitely, but truly there are some cases that respond well to the conservative treatment, ending by the catch knee. So a small hand about the catch knee, it opposes the effect of parathyroid hormone. Of course, it is secreted from the paramedullary cells of the thyroid gland. Before they thought that it is from the parathyroid. It is not. It acts to reduce the calcium level in the blood via 2 mechanisms. The first one is inhibition of the calcium absorption, and the second, and look at this, this is very important, I will come back to this again. It inhibits the osteoclastic activity in the bone. It inhibits the osteoclastic, which means that to some extent it might reduce the blood perfusion at the osseous level. And from this, we will talk about the mechanism of action. Calcitonin found in fish, birds, and mammals. Of course, the one in salmon is more potent than the human one. It's available and cheaper. The mechanism of response, as I said, it's mostly vascular. Nobody knows exactly what it is. But it is the idea that when you reduce the intra-osseous blood, as I said, you reduce the osteoclastic activity. So we might shift the blood to the radicular system, to the radicular circulation. So indirectly, we are improving the blood supply to the nerve roots. Nobody knows exactly how the mechanism, but this is the one. And of course, as Dr. Samy said in the morning, it has a very potent analgesic effect. There are other indications, of course, for salmon calcitonine, which is musculoskeletal osteoporosis, hypercalcemia, Paget's disease, and bone mets. By the way, in Paget's disease also you have associated lumbar canal stenosis. So when we look at the X-ray, we need the integrity of the facet joint and the pedicle, the spinous porosis, the disc space above and below. It gave us an idea about the stability, and we might call it mesostable because of this. But not only that, even if we look at the plain X-ray, Dr. Farah can comment on this, if we have a reduced interpedicular distance, we can simply say that there is a transverse reduction of the transverse diameter of the spinal canal, which was, as we said, reduced interpedicular distance leading to transverse stenosis. Well, why I put these slides? Because I think we always ignore the state of the muscle. The muscle is very important as a supporting force to our backbone. So we easily can compare a healthy muscle like this to another one with extensive fatty degeneration like this. So definitely the support is important. And by the way, easily, when you look at the MRI in the axial view, you can comment on the muscle. You can easily detect the extent of the degeneration of the muscle, especially when you are dealing with old people in the canal stenosis. Well, what to do? Of course, we have many options. It depends, as I said, on the level, on the severity, whether it is bilateral or unilateral, which is usually bilateral. So we can start from the very limited procedures, do laminotomy. We take part of the lamina of the disc and decompress it. But is it enough? I don't think. This might be working in cases where we have a central pathology like a disc compromising nerve roots. But when it comes to stenosis, you need more than that. You need to make a sort of undercutting to the lamina as well as part of the facet joint. And as I said, it's not usually one level. It might be 2 or 3, so you need to make it like a step ladder, laminotomy. Still, it is laminotomy because we are keeping part of the lamina. But the most important that the pathology coming from the facet, and we have to make partial facetectomy. And not in all cases you need to compensate with fixation. Yes, fusion is there. But mostly when you have hemifacetectomy on 2 successive levels on the same side. But rather than that, yes, you can go for extensive laminotomy without affecting the stability of the spine. And as I said, it's not usually one pathology. It's not only the facet arthropathy or what we call it megafacet. No, you have a protruded disc, which usually calcified disc. You have to deal with it, as well as the ligament. Look at the ligament here. How far it is hypertrophied. It's only ligament, what we see, in addition to the megafacet. So what is the lamina that we will gonna take it out so we improve the canal diameter? As I said, that if you needed to go for laminectomy, even if multiple level laminectomy, go for it. And remember that in old people, a little bit we have a pathological stability because of this osteophytosis. Yes, it is pseudoarthrosis, a kind of pseudoarthrosis, but it adds more of this to the stability of the back. Is there any rule for surgery like this in lumbar canal stenosis? I don't think so, because the main rule is to make complete decompression for the canal. So to go and put electrode SCCI, spinal cord stimulation, just to alleviate the pain, it's very uncommon to be used in cases of canal stenosis. Well, I wish you have a good spine, and I wish all the people stay.
Thank you, Dr. Sam, for this excellent presentation. I think it's a big task for the neurosurgeon or the orthopedic surgeon to work on this field because of the spinal instability which might you face. So, well, we'll open the floor for discussion now. Is there any questions, please? Yes, please.
I have good experience to apply corticosteroids intrathecal into the channel, into the spinal channel, in the deep of maybe 5 or the 5th or 4 or 5th spinal segment. This is an off-label usage, but it works very good. 10 milligrams of PMCO, for example, and is more powerful than the epidural application.
You use already the electrodes.
No, corticosteroids.
The what?
Steroids.
Steroids up the steroids.
Yeah, but in the spinal canal, not epidural.
Oh, yes, exactly. I mentioned it in between, but I didn't focus on. But you're absolutely right. Of course, there is a rule of steroids. But again, in the stenosis, it's not like in the other cases of disc prolapse, single disc prolapse, or facet arthropathy. Because as I said, the main pathology is the stenosis. But of course, it still has its rule. But 50% improvement, that's a very good percentage.
But it's temporary. It's temporary.
Yeah, this is the point.
Dr. Samy, just for me, can you please clarify what you mean by neurogenic intermittent claudication? Because of the audience, they will not. And what's the difference between the vascular claudication?
Yeah. This is a very good point, and always we are asked about this. Even sometimes we have to refer our patient to a vascular surgeon because of this. The patient is usually describing the pain like the vascular pain. Whenever he is walking or standing or making activity, particularly in erect position, he had the pain more in the lower limbs. But to differentiate it from the vascular one, it's starting in the back, so there is back pain, and it goes down to the leg, usually above the knee. In the vascular claudication, it is usually below the knee. The other thing that in patient with vascular problem, you have to rule out the pulsation defect, the peripheral pulsation. So we have to differentiate between this and that. Of course, the patient with neurogenic claudication also, they did improve when they lean forward. And this is what actually they do. They walk for a distance, they start to feel the back pain as well as the leg pain, and they sit and lean forward just to improve the circulation.
And of course, any neurological deficit may appear after walking. For instance, lost reflexes or partial foot drop. Well, okay, this is the last question, please.
Thank you, Dr. Samy, for excellent presentation. I want to ask about the role or indications of fixation, spinal fixation after spinal canal decompression.
Yeah, of course, this is important. And as I said, that whenever we have facetectomy on two levels, on the same side, I think it's better to go for surgery, for fixation. But of course, this is totally dependent on how much your patient is ambulant, how much the neurogenic deficits are there. Because sometimes I go for facetectomy, and I decided not to do the surgery because of other concerns, not to do the fixation because of other concerns, the general condition of the patient. The patient is not fully ambulant, is not actively ambulant. So what to do? Just try as much as you can to save the neural tissue. And this is valid, just to save it. And when the patient starts to walk and have a sort of progressive instability, yes, you can go if the general condition will allow you. And the bone, don't forget that we are dealing with mostly a kind of bone which is fragile or osteoporotic. So if it allows you, yes, there is still room of fusion or fixation in canal stenosis, particularly when you go and take the facet joint more than hemifacetectomy.
Okay, thank you, Dr. Samy, for your excellent presentation. I think we are running short of time, and I'll leave the floor for Professor Abdullah Malki to